Dear Chairman, thank you for the invitation to present at this year's EBC. My talk is entitled Intravascular Imaging and Artificial Intelligence, How to Decide When and How to Use It, the Present State and Future Trends. These are my disclosures. I think firstly we outline what we really mean by artificial intelligence, and the overall umbrella term really focuses on a program that can sense, reason, adapt and act. Beyond that, then we drill down into machine learning, where there are algorithms whose performance can improve our understanding of data. And then even more so, deeper understanding of these large data sets with the use of multi-layered neural networks can further enhance our utility of data. And in fact, already we have elements of all of these at play within intravascular imaging. And I thought, firstly, I needed to challenge the question that's been set to me, because to decide when and how, I think, opens up a potential problem here, because the when offers up this interaction with human intervention, and that could pose a problem. Now, clearly, we're awaiting the outcomes of trials such as Illumian 4 in October, which may well guide us very much more on the when, but I think for the moment it's important for the purpose of this presentation to focus on the how we may use intravascular imaging and AI. In the present state, we have co-registration across a number of different industry tools, morphology through the most recent Ultron, but also through virtual histology IVUS and the use of NIRS IVUS, vessel dimension support available now through Ultron, bifurcation software with both Abbott and Terumo, and then Stent Optimisation, which in my mind, I think is currently best undertaken with the Abbott software. And I'll highlight examples of this using an Ultron case. So this is a complex left main that I had as a recorded case with significant LAD disease, extending from left main distal through into also an angulated circumflex. Co-registration here by OCT actually offers us a much better understanding of what's potentially ambiguous angiogram. If we then overlay on that morphology, here we see with a threshold of 60-degree arc of calcium using this new Ultron AI software, the ability for us to detect calcium throughout this circumflex vessel. Now, we may want to increase the sensitivity, so we look at a 180-degree arc, which may be clinically more relevant, and we see actually that there's relatively short segments of calcium now within this circumflex vessel. We compare that against the 60-degree assessment. Actually, then that poses a difficult clinical conundrum, because here we have a horseshoe of calcium, slightly underappreciated by Ultron. Here it's saying 187 degrees, it's probably closer to 220 degrees. And really now the question is, do you take a non-compliant balloon, a cutting balloon? Should we up and debulk with rotablation or CSI? Should we be taking IVL? And I have to say I'm not sure, and we'll hear people with very firm opinion. But the reality is machine learning and observing the decisions we make and the outcomes that we achieve may well facilitate for us a far more enhanced decision-making process. Beyond that, I think there's also a cautionary note, which is this is the example of the pullback actually down the same patient's left anterior descending artery, where I failed to clear the vessel of blood, and we see lots of red delineating a question over the quality of lumen demarcation. And if I overrule that, again, a human intervention, then actually we start to see recognition inappropriately of calcium to a point where, had we been led by the machine, we may take more advanced adjuncts such as IVL here to fracture what's said to be 317-degree arc of calcium, where in fact there's no calcium at all. So we must be sure that we react to an output that is from a good quality input. Now, beyond that, then we might start thinking about the stent. And this is a lovely anecdote given by a colleague in London, Richard Bogle. Would you actually buy a carpet from a bloke who stood in the corner and said, I think you need a 4x23 Axminster there for you, sir? The carpet's not going to fit. So we need precision tools in order to ensure that we make the right decision. And we now have available this co-registered ability to select where we want to land our stent by angio, but then also by assessing our proximal and distal landmarks. And here now we have recognition automated of the external elastic lamina, which was very poorly achieved by human method in Lumion 3. The next decision, though, then is the bifurcation strategy. Now, I make a decision due to discrepancy of vessel caliber, angulation of the circumflex to do a DK crush. But actually, it may be that through the assessment of the geometry, the assessment of the tissue, that actually a machine may tell me different in simulating the different techniques that could have been used in this bifurcation. The next step following stenting and optimization with ballooning and wire cross would be to use bifurcation software. Here, an example using AptiView. Ultron, sadly, at the moment doesn't have bifurcation software available. And again, we see from the beautiful consensus led by Yoshi Onuma that there are a number of different potential scenarios of where our wire could cross. But a machine, again, may assist us in making that more nuanced decision. This is the angiogram.
Looks good.
It looks good, I say. But can we be sure? Really, we have to move on to take the OCT. So here is the OCT taken down the LAD. The white lines tell us immediately no malapposition. We can turn then to look at individual segments, again through human interaction at this point, but this may become automated in the future. We have an MSA of 16 proximal, and then using the Illumian criteria, half and half, proximal half 6.5 MSA, distal half 4.6. So we're happy. We could use tapered mode, and here we see actually again an MSA of 4.6 in that distal third of the LAD, but no evidence of underexpansion below 80 to 80%, all automated. We also highlight areas of malapposition which are not adequate, so there's the requirement to go back and further optimize with further ballooning and recross into a side branch. This is the final result.
As an MSA in the left main.
Just for the purpose of speed, I'll show you those results. And geographically, we see a very nice result in the LAD in the cranial view, and we see a very nice result in the caudal projection for the circumflex here in the spider. So what does the future hold? Well, there's some really exciting technologies available. This was recently published in Eurointervention from a Chinese group here highlighting enhanced tissue characterization, being able to delineate lipid, fibrous tissue, and calcium, and then also superimposing a remodeled vessel contour for the purpose of achieving an OFR ischemia assessment, maybe both pre and post stenting. Beyond that, we've seen the incredible advanced simulations led by Yanis Chiatsis in Nebraska, and the potential then for us to model different scenarios of bifurcation, also limited by the potential soft or stiff nature of the vessel according to the tissue characterization by OCT. So that hope that we might actually have a machine that could tell us the most optimal bifurcation strategy could become a reality soon. So how to decide when and how to use AI? Well, I think we have to reflect that we have the potential both to make or destroy these technologies, and that's mainly through our ego potentially overriding or driving decision-making. We have to let the machines take some of that control, but there is clearly an interaction. Machine learning provides a really exciting potential. We have the potential of a calcium-based algorithm decision-making, a bifurcation strategy decision tool, the potential for AI-guided optimization. But success will absolutely depend on our intelligent engagement with these technologies. I thank you for your attention.